always say, if you talk to 5 different doctors or dietitians or clinicians or people, you're going to get 6 different dietary recommendations, right? So I think
Right.
the beauty of nutrition science and what we know in medicine, or what we don't know, I should say, is that there are so many different ways to be successful. That's kind of how I like to start, right?
Yeah.
And I think in a way that it's confusing because I can't just say everybody do this, but it's beautiful in the sense that if you lean vegan, like, I'm not going to say, you have to eat meat, 3 times a day, because I know people can be very successful on a vegan diet. That being said, if you asked me and you kind of said, what would I do personally to try to be more metabolically healthy, whether it's to, improve my blood sugar control or reduce weight, then I personally lean towards low carb diets.
Welcome to the Protecting Your Nest podcast, a podcast where we explore the root causes of chronic disease and uncover strategies for optimal health and healing. I'm your host, Dr. Hampton, and today I'm thrilled to be joined by Dr. David Ahn. Dr. Ahn is the Chief of Diabetes Services at Hoag and the Program Director of the Mary and Dick Allen Diabetes Center. A specialist in endocrinology and diabetes care, he is passionate about integrating cutting-edge technologies such as continuous glucose monitors and smartphone apps to empower patients in managing and even reversing diabetes. Known to many as the diabetes doc on TikTok, Dr. Owen uses his platform to educate and inspire thousands about living healthier lives. In this episode, we'll dive into the challenges and opportunities in diabetes care, discuss the role of low-carb and ketogenic diets in managing metabolic health, and learn how the doctor has looked at innovative approaches in helping patients achieve remission in type 2 diabetes. And with that, Doc, I appreciate you joining me on Thanksgiving morning. Might as well throw that out there to have a
Yep,
conversation today. So thank you so much, my friend.
of course. Yeah, I guess an appropriate day to talk about nutrition and
That's
diabetes,
right.
right?
That's right. It'll be interesting. I share in previous episodes that as a doctor who's more low carb, I don't indulge in a lot of the things that I once did. And one of the things that always kills my belly because I have irritable bowel history is that dressing or stuffing, depending on
Mm,
what neighborhood you're from. And man, I tell you, it's
yeah.
just so rich. My body just can't tolerate it. So I always have to pause and see if my mom's gonna like try to put it on my plate regardless. But she's pretty good now at not forcing that. So it's always going to be interesting. So I'm looking forward to that in a couple of hours. So let's start off
Definitely.
and make sure my audience gets to know you. And I want you to share your journey into endocrinology and what led you to really focus on diabetes in particular.
Great question. So I, like many people in medicine, as you know, I wasn't quite sure what I wanted to do. I knew I wanted to be a doctor. It was kind of, my dad is a cardiologist, and so it was kind of always the next step, and nothing else derailed my path towards medicine. I didn't become a basketball player or, fall in love with computer programming or anything like that. So I kind of just followed the path that was ahead of me, and I did well in school, and in medical school, I was kind of not sure what to do. So I went into internal medicine because, as you know, it kind of, if you think of it like a tree, it keeps the
That's
most
right.
number of specialties open, and you get to learn a lot about general medicine as well. And during my internal medicine residency, I was very passionate about technology, just like consumer technology. This is like the iPhone age, the activity tracker age with like the Fitbits and Jawbone ups and Nike Fuel Band. I don't even know if you remember that. But so I was doing a lot of reviews of these fitness trackers for an online blog called imedicalapps.com. I don't think they're still actively updating. And they asked me to review a iPhone connected glucose meter, and
Mm,
I reviewed it and I was like, wow, this is so crazy. And this was back in, 2010, 2011. I said, this is so crazy that you can use your phone to track your blood sugar. And, I had friends of mine who would come up and they'd be like, what are you doing? Like, can I check my blood sugar? Which is a very, as you know, as a clinician, nobody wants to check their blood sugar with the finger stick machine. So I was like, wow, this is really exciting. And I think my mom was diagnosed with type 2 diabetes when I was in junior high. And I just remember that being a very um, transformative time in my life just
Mm.
because it impacted her emotionally. I remember, there were tears and we're trying to console her by making horrible tasting sugar-free ice cream or whatever. And so I just remember that part of my life. And so I always kind of, my ears would perk up in medical school whenever there was something diabetes related, just because I thought potentially I could help my mom. And then lo and behold, my passion for technology, my interest in diabetes just through my mom kind of married perfectly, because I think in medicine, um, I think diabetes is actually probably the most closely intertwined with technology. They're kind of the forerunners in a way. And so it's been really exciting with, insulin pumps and continuous glucose monitors. Um, there's been a lot of opportunity to explore technology and the
Mhm.
intersection between health and wellness with technology. So I just decided to go into it kind of on a whim, and I've been really happy I made that decision.
Nice. Yeah, I remember when my wife, who just happens to have type 1 diabetes, she's
Oh,
a
wow.
pharmacist. So when she uh, got this adult onset diabetes, it was tears and it was a moment of, and you're right. I think that's the thing she fusses about the most is, initially, wanting to be able to do what she previously did, but more importantly, having to not think about it. You know what I mean? Like, and in some ways, in a weird way, we all should be thinking about what we eat regardless. But I think when you have these diagnoses, it makes it very difficult. And we also want to console our family members. Thankfully, they do have some tasty options. You have authors out there like Maria Emmerich and others who are trying their best to help us have options that allow us to enjoy these dietary patterns. But again, it's a family event when it happens, and we have to work as a team. You're leading some folk as chief of diabetes services, and I'm curious, what exactly are you doing in that role, and how much are you interacting directly with the patients?
Great question. So, yeah, as chief of diabetes services at my healthcare system, Hoag, we're in Orange County, California. I'm still quite clinical. So I have 3 days of clinic and 2 days of admin slash research. That's kind of how my schedule is broken down. So I still get to be in the trenches, helping patients, understanding, what's evolving, understanding patient needs. And that's 3 days a week. And then the 2 days that are more administrative, I oversee some of the policies in the hospital. So, for example, at the moment, we're actually restructuring our insulin order sets for patients that are hospitalized who need better blood sugar control. Also, I oversee our research program. So we do a lot of research visits with, pharmaceuticals, diabetes
Mhm.
devices, some general endocrinology clinical trials as well. So that's kind of what I oversee. Oh, and I guess I oversee the two diabetes centers. We have
Mhm.
obesity and an obesity center and diabetes centers. They kind of share the same resources, but we have two locations. So we have one in Irvine and one in Newport Beach. And I'm the director of those two centers as well. So I oversee the clinical staff there, the dietitians, the nurse educators, and the physicians that work there.
That's cool. That's a big shift from maybe how you started your career. Not often are we in leadership roles, and you kind of fall into it, or somebody kind of says he's a great doc, let's get him doing that. But I really appreciate you, because I remember when the pandemic was going on and we said these are the heroes, the healthcare folk, but should we not forget the research? Because in order to kind of prove that what we believe is going to work for you works, we got to, and particularly when we're talking to our colleagues, they need to see some science. So I really appreciate that you're in that research space. That's a really important place to be. And because we didn't necessarily know each other before this recording, I'm always curious. See, a lot of people, when they bring people to their podcast, they target a particular demographic that are already indoctrinated into their beliefs. But I like to live on the edge a little bit. But what I want to know from you is, you're an endocrinologist. Many endocrinologists in my health system are a little cautious about keto, for sure, and I would argue low carb at times, and definitely carnivore. So, where are you on that whole spectrum? And what are you seeing in your colleagues when you start talking about diet as a way to deal with this diabetes diagnosis?
Yeah, it's obviously a complex discussion. I think the way that I always approach it is I kind of start with a quick joke. I always say, if you talk to five different doctors or dietitians or clinicians or people, you're going to get six different dietary recommendations, right? So I think
Right.
the beauty of nutrition science and what we know in medicine, or what we don't know, I should say, is that there are so many different ways to be successful. That's kind of how I like to start, right?
Yeah.
And I think in a way that it's confusing because I can't just say everybody do this, but it's beautiful in the sense that if you lean vegan, like, I'm not going to say, you have to eat meat, three times a day, because I know people can be very successful on a vegan diet. That being
Mhm.
said, if you asked me and you kind of said, what would I do personally to try to be more metabolically healthy, whether it's to, improve my blood sugar control or reduce weight, then I personally lean towards low carb diets. I think that might be a bias just because I directly help people with diabetes every day, and diabetes is largely
Right.
a
Right.
carbohydrate induced condition, or at least type 2 diabetes is. So that might be a little bit of my bias, but so I generally lean towards low carb dieting plus or minus intermittent fasting if that's something that works in your schedule or in your kind of behavior patterns. But I am very aware that those two things are not the best options for every person. And like I said, it's great that there are options for other people. One thing I do like to
Mm.
add, though, in favor of low carb is that I think I share a lot of the struggles that my patients have. Like, I am not the type of person who can just eat chicken salad happily 3 meals a day. And, I'm not like, if I had my own, if I was left to my own desires, I would not eat very healthy. And I think I can empathize a lot with my patients on that. And I think for patients who struggle with those types of behaviors, like myself,
Right.
I think low carb dieting and intermittent fasting is kind of a good framework to kind of work within, because there are exchanges you can make that still leave me satisfied, right? Like, I'm okay with giving up fries, which I absolutely love, if that means I can have a little bit more protein and fat, or meats or something like that.
Yeah.
So at least my mind can negotiate that and be like, okay, well, at least I can have a little bit more meat. And so personally, and I think for many of my patients, low carb dieting is a great option.
Yeah, that's great. And again, meeting people where they are. Um, I try really hard to do that in 2023 at the Symposium for Metabolic Health in San Diego when I spoke. My topic
Cool.
was how vegans and carnivores can live in harmony, and a lot of it was meeting people where they are and
For sure.
recognizing that when people make dietary decisions, it's like you said, complex. It's not like just one thing. And it may be my religion, it may be my respect for animals in a way that's different than maybe an animal person would respect animals. So I just think that's the world we want to live in. We want to live in a world where we are understanding that we're all trying to just achieve metabolic health, right? And we then have a right to choose our path. And if we struggle, and we'll touch on those tools in a moment, if we struggle, we have ways to know we're struggling, and then we need to mitigate that and do something different. This is not rocket science. Now, we also talk a lot in the low carb community about reversal, remission. We use that type of language. And that language is not always favored in the endocrinology world. I've seen, at least from a conventional. So, how do you deal with this language of diabetes going into remission or reversal for type 2, of course? And how often are you seeing that in your practice?
Man, going straight for the controversial questions. No, this is great.
Why not?
I know. It's nice to meet you. No, just kidding. But yeah, so when it comes to diabetes remission and diabetes reversal, um, I I am of the belief I'm not a fan of the term diabetes reversal because I think it can be misleading. So I think
Hmm.
when the layman person hears the term diabetes reversal, I think they hear the term cure, and they think, oh, if I can reverse my diabetes, I can cure my diabetes. Um,
Hmm.
but I guess if you want to be very literal, then reversal means kind of going backwards, right? And that is true. You can move your diabetes backwards in the sense that you can, with aggressive dieting and lifestyle modification, yes, you can reverse the pattern of your diabetes and get to an earlier state in your condition where you can have good control without medications. So technically, the term is right, but I just worry that it gives off the wrong connotation to people who will hear
Hmm.
reversal and think, oh, I can cure my diabetes and not have to deal with my diabetes anymore, which is not at all, I think, the message that anybody who believes in diabetes reversal is actually communicating. So I do think it's a little bit of a clickbait title, perhaps. So I favor the term remission because I think when people hear remission, they think they have a little bit more of a nuanced understanding, right? Because you think of cancer remission, where it's like it can come back,
Hmm.
but thankfully I don't have to deal with it right now. And I think people have that kind of connotation when they hear the term remission, which I think is appropriate in diabetes because if you control it well and you lose weight and you've made really important dietary and lifestyle modifications, you can get to a point, or you may be able to get to a point where you don't need to take medication and you can have really good numbers. But that doesn't mean you can't, if you fall back into bad habits or if your metabolic state worsens, yes, you can go back into having diabetes and needing to be on medication again. So I prefer the term remission. I understand why people try to use the term reversal, but like I said, I just worry it can be misleading. And I think one thing I always like to add when it comes to this discussion is that it's important that people understand that not everybody can achieve diabetes reversal or remission with lifestyle
Hmm.
modification alone. And I think sometimes there can be, you'll see these like keto warriors or whatever kind of blame the
Right.
victim when people can't get their A1C at a certain goal. But depending on where you are in the progression of diabetes, and of course, in this
That's
context,
right.
we're only talking about type 2 diabetes. But depending on where people are in their progression with type 2 diabetes, they may be doing everything right, but their body just may not be making enough insulin anymore.
Yeah,
So,
that's right.
that's the other thing I like to layer in there is that not everybody can achieve remission. Many people can, but not everybody can achieve remission um, with lifestyle modification alone.
Yeah, I love your framing. I like your tone, and this is how we have, during the Thanksgiving day that we're gonna enjoy later. People are gonna be afraid of talking about politics, right? And they should be,
Right.
but they also shouldn't be. We should be able to have conversations around topics that some perceive as controversial. Now the irony is that I don't consider this controversial at all, and I'm gonna say why. Because even when I wrote a book called Fix Your Diabetes," and in the title it says your dietary solution to reversing. Now, I used that language at the time. Now, this is a cool thing is that I agree with everything you just said because there are some problematic issues with using a certain type of language, and this idea of reversal does align with cure, and we know that's not really what's happening. I think it oversimplifies things. Obviously you can't speak that language for type 1 for sure, but I think it makes it confusing for people because I have an irritable bowel problem, and if I go back to eating that crap I was eating, it's coming right back. It's not gone, it's
Right.
just in remission, right? So I think that type of language, and I like the reverse. I like the remission also because it it just keeps people accountable to continue the actions that led to them not having the symptoms, rather it's diabetes or some other condition, and it just allows for them to continue down that path. So I do think that we have to be careful, and I think as long as we're explaining things, and sometimes in a Twitter tweet or in a conversation you just happen to come across, you're not getting the nuance, and when you're missing the nuance, you walk away with unrealistic expectations, and some people reverse and then they go back to what they were doing. So it's just not going to work that way. It's a lifelong change. So I'm really happy we're having this conversation. I'm happy I didn't know you, so I can kind of ask and just pause and see what you're going to say. But I love that because it makes it more intriguing for me as we have this discussion. Now, having said that, let's talk a little bit about technology. The continuous glucose monitor is a beautiful thing. My wife, again, has one. And I may even wear one just for fun, just to see what it does for me as well. And insulin pumps, all of these things. So how much of that is incorporated into the patients that you're kind of overseeing, rather through the doctors or yourself, and how big of a difference has it made?
Yeah, I'm a big believer in continuous glucose monitoring. I feel like I often refer to those and the GLP-1 class, which we may talk about at some point, but they're kind of like the iPhones of my medical life, like they came and they totally changed
Yeah,
the world. And I think,
right.
the world won't look back or it'll be hard to think of a time before them. And so, yeah, it's, my career, which is relatively young so far, has already had two like transformative things happen, but I'm a big believer in CGM. And
Hmm.
so I prioritize, or my primary interest is type 1 diabetes. So like you implied with your wife, that's kind of a mainstay of therapy there. I think it's standard of care. Not every single person is ready yet to be on a CGM, but if they are willing to wear a CGM,
Hmm.
I believe it's every person with type 1 diabetes should wear one. Um, Beyond that, I think you're seeing expanding indications. So now the most recent Medicare guidelines have it recommended for anybody taking insulin at least one shot a day, or anybody at risk of severe hypoglycemia. And I think over time it's going to get the net is going to get wider and wider to incorporate more people.
Yeah.
And then also, um, in August of this year, 2024, there were actually two over the counter or direct to consumer CGMs that were released on the market, the Dexcom Stelo and Abbott Lingo, that don't require a physician prescription. So you can just order it directly from their websites and you can have a consumer experience using a continuous glucose monitor. And I think we're just opening up that whole world of like metabolic health and wellness, which is risky. I think just like the health and wellness community, I think there's good and there's bad. So I think
That's right.
there's potential excitement and pitfalls, but I think the world of CGM is just going to get bigger and bigger, and it overall I think can be a very helpful net positive, especially for people like you and I who are favorable towards low carb dieting, because in the
Hmm.
end, I think in many ways, these CGMs are essentially carb detectors. And so
That's
they
right.
can be a real truth teller when it comes to what you're eating or when you're eating. And I guess I'll pause there because, there's a lot of stuff we
Yeah.
can talk about and maybe we will.
That's right. Well, I'll say this: when you have a patient in front of you, and let's just say we didn't give them a handout that says "eat this, don't eat that," and it tends to lean low carb. If you just give them that damn monitor, right, that CGM, and just say "don't eat what spikes you," I mean,
Yeah.
3, 6 months later, they're good. You just avoid the thing. So the monitor just gives you that right in front of you, instant feedback, and that's what I love about it. And again, I hope that we continue to expand. I worry a little bit about, uh, you know, sometimes you don't even see the over the counter versions on the shelves, and I almost feel like the stores are just kind of pausing a little bit because maybe they make more money when it's a prescription. I don't know, but it just seems like I don't see them as available. So hopefully that'll change very soon, and people can have access, and more people, even those who are just trying to be metabolically healthy, they'll have access to it as well. So there's a lot of things. You're on social media, on TikTok, and I do appreciate that. But there's a lot of myths out there because pretty much anybody can. They don't. You have to be an endocrinologist to have an account and you can, get in front of the camera. So, um, what are there myths out there that you are constantly hearing your patients say to you, and you have to kind of spend time debunking them?
Great question. I mean, there's a ton, and I think you're right. Social media has just, expanded that by a lot. I think the most dangerous one that I think is really important is to really understand any myth that has to do with conflating type 1 and type 2 diabetes, right? I
Hmm.
don't think this is necessarily the most common, but I think this can be the most harmful because that's where, by definition, someone with type 1 diabetes is going to need to be on insulin until there's a
That's
cure,
right.
which we don't have yet. So I think, there's a lot of conversation about, trying all these different herbal remedies or going extreme keto or something like that. And sometimes this can be guided towards diabetes, or whoever's talking is kind of clumping all diabetes together. And that can be very harmful for people. Maybe you're newly diagnosed with type 1 diabetes, you're desperate for an answer. And so you find some guy online who's telling you that you can reverse your diabetes, and you don't realize, and that person's not making it clear that they're talking about type 2 diabetes and not the type of diabetes you have. And that can cause, medical problems because you're trying solutions that are not going to work. So I think that's the most harmful. Which is why I start there, because we're trying to do no harm, right? But I think
Yeah.
beyond that, I think a lot of it just has to do with, I think, people being overly prescriptive of kind of what we were talking about earlier. I think saying that going vegan is the only way, and like it's the far superior way, and everybody has to be a vegan.
Right.
Or similarly, these keto warriors who are kind of like, yes, you have to be keto, everybody else is horrible. And
That's right.
like I think we both were aligned that you can be successful with both philosophies. And I think there are really good messages in both, which is, for in the vegan community, like the quality of your carbs is so important. Eating whole foods is so valuable, and that has a positive, favorable impact on your blood sugars. Similarly, extremely limiting carbohydrates is going to be amazing for your blood sugar control as well, and often for weight loss. So I think people just being too narrow-minded, or maybe too like tunnel vision, having too much tunnel vision into one treatment option or modality, I think can be harmful for people because, like we also talked about, people are different. And, you may have a certain favorite
That's
flavor
right.
profile, or you may do really well eating 5 small meals a day, whereas other people do really well eating one meal a day. And that person who can be more successful eating one meal a day may end up eating 5 big meals a day if they're told to eat 5 small meals a day.
Right.
And so I think it's really, I think people, we kind of talked about this already, they just lack nuance a lot of times in these, in like
Hmm.
a quick article or in a quick video. And a lot of times, as you know, the types of videos and the types of content that go viral are going to be by definition controversial or edgy or
That's
extreme,
right.
because that's what people watch, and that's what grabs your attention, and that's what people share. And I think um, there's a lot of danger in that. And you were kind of alluding to this earlier. I'm a big believer in like not having sticking to the extreme, so I try to find the good in every message. And I think there's a lot of good that can be communicated, but sometimes the extremist flavors to it can sometimes throw things off. So
That's right.
hopefully, in general, as we discern medical advice or health and wellness advice, that we try to find the good in it and kind of discard the bad.
Yeah, that makes sense. It's so funny. I'm thinking about a couple of videos on my YouTube channel. I released a video saying I need your help and asking the viewers to give their thoughts about how we can improve healthcare. 400 or 500 views. Then I did a video saying, here are the top 10 keto and carnivore lies. That big word lies and highlights
Yeah,
13,000 views. You know what I'm saying? So it's like,
yeah,
so
yeah.
you're right. You shouldn't have to sell your soul to educate the public, but unfortunately, people are attracted to a little drama. And one thing that I want to ask you as an endocrinologist, real quick, it's not really a myth thing, but it's like I want to speak about the GLT2 inhibitors and Jardius being one. And so the Society for Metabolic Health Practitioners, Low Carb USA, they have guidelines for therapeutic carb restriction. In their guidelines, they say, if you're doing keto, be cautious with the drugs because of this ideal of euglycemic ketoacidosis. So when I've talked to my endocrinology friends, they'll say, it's not that big of a deal. And then but so how have you dealt with this issue? Because you have patients who are gonna lean low carb potentially, some go to keto, and then you have the drug that we're giving out like statins, like to everybody, right? So has that been a big issue in your health system in terms of how you have that conversation with patients?
So to clarify, there's two classes that are kind of lumped in here. There's the GLP-1 receptor agonist class that includes things like Ozempic and Mounjaro. And then there's the SGLT2 inhibitor class, which includes things like Farxiga, Jardiance, Invokana, things like that. They both
Yep.
technically are at risk of increasing your risk of euglycemic DKA, diabetic ketoacidosis. But the risk of the GLP-1s, in my clinical experience, is essentially minimal. Like that,
Mm.
even though it technically is on the label, I don't functionally consider it essentially at all. With
Yeah.
SGLT2 inhibitors, though, it is definitely a real phenomenon that can happen. And so it is important to educate your patients about it. And layering on top of SGLT2 inhibitor usage, a low carb diet, yes, it can slightly increase your risk of having euglycemic ketoacidosis, or you can get confused because, the typical ways of screening for DKA would be given a false positive if you're on a keto diet, right? Because you test it using ketone sticks. And if you're if you're in DKA from euglycemic DKA from SGLT2 inhibitors, your urine keto stick will be positive. If you're in
Yeah.
keto in the ketogenic state from a keto diet, your dipstick will be positive. So there's also kind of just confusion in knowing which is what, right?
That's right.
So
Right.
I think it's important. What I just and I think most endocrinologists have been burned by this. We do have patients that have had to go into the hospital and
That's
get
right.
IV
That's right.
fluids and get insulin because of euglycemic DKA from SGLT2 inhibitors. So it's definitely real. It's not common, but it's definitely real. So I generally just tell patients to really understand the symptoms because you can't just,
Hmm.
especially if you're on a keto diet, you can't just trust those urine ketone sticks. So you really have to trust your body and listen for your symptoms, which is going to be nausea, vomiting, GI symptoms like that. And then that plus maybe a positive ketone test, then at that point, go to the hospital. So I think it just requires a little bit more education, but I also think the SGLT2 inhibitor drugs I'm not prescribing as much, just because these
Right.
GLP-1 drugs are so effective, and weight loss is generally something that my patients with diabetes want as well.
That's right. That's right. That's a great answer, and it's also it aligns with what I've done, because even if I didn't prescribe the drug, the SGLT2 inhibitors, my cardiologist or endocrinologist may have. So I'm always having to have this conversation, but I think it's good because one of the benefits of these platforms is that people are like, oh, maybe they hadn't talked about this with their doctor and they just happen to be doing low carb or keto and they're taking a drug like that. And now they can say, okay, let me go back and talk to my doctor, which is what I would advise people to do to kind of get a little bit more nuance, maybe do your own Google search about what those symptoms look like, and then you can start becoming aware even before you see the clinician. So thank you for that. When I see patients in clinic, I kind of lean lifestyle heavy, and then I use pharmaceuticals. I have people taking GLP-1s. I'm an obesity doctor. Even if I didn't want to, they're going to come in and ask for it. Right? It's
You go
like,
out of business real fast if you didn't talk about
yeah, I
GLP-1s.
go
Yeah.
into business. Exactly. I gotta use it. So I just try to lean towards lifestyle first. So when you're in your clinical practice and not doing research, how heavy do you lean lifestyle versus a pharmaceutical approach?
That's a great question. And I think I probably don't lean enough into lifestyle modification, to be perfectly transparent and vulnerable. I think it's really important. Um,
Yeah.
but I think, I mean, my defense, in my
Let me
defense,
let
I
me
guess
ask
I
you
would
this: Is
say
that the endocrinology? Is that endo? Because in my stereotype is that endocrinology is very pharmaceutical centric. It's just but I would say all of healthcare is in the conventional model. So
correct.
how
Yeah.
much of that is? Yeah, 'cause they have to. When they see you, they've already seen me, so they need a
Correct.
fix. Yeah.
Right, that's what I was gonna say. Like in my defense, I would think that people are generally going to see an endocrinologist either because their referring doctor, their primary care doctor, has kind of tried other things and said, "Hey,
Right.
go talk to Doctor On," or they're doing their own research and they really want to get answers about I don't know, a technology or a medication. I think generally people are not thinking, "I need to change my diet and change my lifestyle, I'm going to go find an endocrinologist to talk to." But I also agree with
Right. Right.
you,
Right.
and with the underlying frame of the question, which is that I think we, in general, as a medical community, and honestly as patients too, like we undervalue diet and exercise, right? I think um, it, it's tough, right? Like I think the systemically it's just I mean that's why we as a nation we struggle with obesity, right? It's we know we should
That's
eat
right.
cleaner, we know we should stop eating when it's appropriate, and we know we should be more active, yet we spend hours on our phone and make unhealthy choices. And I think that is, from the bottom to the top, leadership to insurers to pharmaceutical companies to physicians to researchers to patients. We all struggle with this both individually and systemically, and it's hard because there's not a lot of money in incentivizing lifestyle modification, and I don't mean
Right.
that
No.
in like this big pharma wants to kill you conspiracy theory method, but it's just true.
Mhm.
Like in the end, we need things to drive. We need finances and we need financial incentives to drive change, right? It's why these
Yeah.
political campaigns cost what $2 billion or something, $3 billion to just get people to vote, right? Uh, you need money or you need systemic infrastructure to change people's behavior, and there's no you know there's no monetary incentive to tell people directly. There's no monetary incentive to tell people to eat cleaner. Obviously systemically it saves costs a ton.
Yeah.
Insurers will save tons of money, but it's just hard to incentivize people. It's I mean we could talk about this all day. It's so the system is just
I
it's
know.
just so hard to change the system.
Yeah. Well, I one of the things that reason why I'm still in a large health system, Advocate Health, we're in 6 states: Illinois, Wisconsin, Georgia, Alabama, North and South Carolina. And one of the things that we have a little advantage is that it's a population health kind of centric model, Medicare Advantage. So there is a little incentive to keep the population healthy. We also are being pushed with patient experience, interesting enough. So if people are not happy with us, we lose dollars. So we have to be better at that. So I agree with you. I think the model that we have in healthcare is one where there's no incentive to do the things. In fact, this is the irony. The irony is that the money I get back if I'm paid based on how sick people are is greater if they're sick. And as they heal and I take away if I have the courage to take a diagnosis off their chart, and maybe I wouldn't if I think about remission, but if I think about reversal, right, then the compensation goes down. So I think the whole model is broke, but I do think that if we can incentivize healing, like if we got paid more because so if the A1C is 5.6 instead of, maybe the average for type 1s is 8.6. If it's down to 5.6, there's bonus dollars to then have money to create programs to help people who need coaching, because a lot of the struggles that you're kind of alluding to is because I don't have support. I need somebody that's going to walk with me. I need a coach. I need a nudge here and there. I have a trainer. I wasn't exercising regularly until I got a trainer. And now it's like I know I exercise. It was late last night. My wife's like, "You're going to exercise?" I said, "Yeah," because my trainer is going to know that I didn't do it, even though she would know. But she would know. I just in my
Yeah,
brain, so I just do it because I'm not going to see her until a few days from now. So yeah, I just think that there's a lot related to this. And one of those things is the emotion of the patient and the psychological challenges of the patient. Now, again, that may be more in the lane of the family doctor like myself, but are you addressing any of that stuff? How do you manage a patient who comes to you who's simply in a bad relationship or depressed or whatever, and they're struggling to do what you're asking because of that?
for sure. And I mean, first off, I should say, I unfortunately, I think you're probably the exception and not the rule when it comes to primary care
Hmm.
providers.
Yeah,
So
no doubt.
I think that
That's true.
philosophically, lifestyle counseling and focusing on mood is huge and very important, especially in the preventative space, which is what primary care is often about. That being said, I also understand that primary care providers have the challenge of managing, 15 conditions in a 15-minute time slot,
Right.
or their
Right.
employers are kind of breathing down their back. So
That's right.
you guys are in a catch 22. It's so hard, but I think it is so important.
Oof.
So I love that that's your message. I love that that's what you're practicing. I love that this is your life philosophy and why you have this podcast. So that's really important. Um, Anyways, but to our system, in my clinic, I think, yes, I think with diabetes, there's a lot of different conditions that are of the, that align with mental health, right? There's diabetes burnout that often impacts people with type 1 diabetes, but also type 2 diabetes. There's a lot of eating disorders in both type 1 and type 2 diabetes. There's depression, right? You hear that there's much higher increased rates of depression in people with diabetes. And so, these are all very real things. And I think, thankfully, and this is where it is nice to be a specialist in the sense that I have my full visit time to focus on diabetes, right? So we can focus on a little bit
That's true.
more of like lifestyle factors. We can focus a little bit more on stressors, right? I always talk to my patients, and usually, probably the two things that lead most to worsening control in my patients is caring for like a loved one who's sick, right? So it'll be like my
Mhm.
mom was on hospice, and I just didn't focus on my health because I was in the hospital 5 days a week. And so that's number one. And number two is like a divorce or some crazy, family
Mhm.
life stressor, or losing a job or something like that. And, it just shows how much of an impact stress and life situation and mood impacts our blood sugar control. And so, these things, it's important for me to factor these in, because if my patient just comes in the midst of a divorce telling me that, they're gaining weight and their blood sugars are high, and I just rail them, and I'm like, why are you doing this? You're going to die. You're going to go blind. Your arms are going to fall off. Then, that person is probably not going to come back to the doctor, or,
That's
make
right.
change, right? They're
That's
not in a
right.
situation where all of a sudden they're going to start going to the gym 5 days a week. So, so I think a lot of it is understanding people's context and encouraging them. I tell people that,
That's right.
we go
That's
through
right.
seasons of our life. There are going to be seasons where we are on top of it, eating everything right, logging every calorie and weighing every piece of food that we consume, and going to the gym. And there are going to be seasons of our life where we're not on our A game. But it's about, you still have to elevate that, right? I'm not saying you're excused for not making good choices, but it's kind of like running a marathon, right? There are going to be times where you're sprinting, and there are going to be times where you're pacing yourself and just trying to get through till you hit the wall and clear the wall, and then kind of get your momentum back. So I think in practice, that's a lot of how I try to incorporate mental health. I think it's also important to be sensitive to like more severe mental health issues, like actual eating disorders or actual depression, and being quick to refer to mental health providers. Um, but that's tough too, because, going back to the healthcare system, I mean, psychologists and psychiatrists who accept health insurance often are booked out for like months and years.
Right. I know.
So
I
that's the
know.
challenge. And so, it's a very complex issue, and it's very tough, but it's real, and we need, as clinicians, to
Right.
be our best when it comes to
Wow, you're on it, Dr. On.
it.
You're on it because, I think, it's a blind spot. I think in my previous life, that was a blind spot for me in terms of, don't you know your arm's gonna fall off? You're gonna lose your leg, your kidneys are gonna fail. And I never took the time to say, well, why are they struggling? So for all my clinicians out there who may hear our voices today, whether you're a doctor, a pharmacist, a nurse, it doesn't matter. Uh, Give people grace and always try to peel that onion back so you'll understand there's a reason why they struggle. And it's not because they don't want to be healthy. There's usually something else that you can support them with. And if you can't do it yourself, maybe your health system has a way to support them. And that's why I think all health systems need to think broader and think about social determinants of health and what can we do to support people, even if it's just a counselor. And what we did in our health system, we have embedded intake coordinators for behavioral health, and we have a team of virtual psychologists who we normally would have to wait. 3-4 months to get them into C, and now it's like 2 to 3 weeks, and it's a huge win. I'm not sure how
That's
they pulled
awesome.
that off, but that's amazing because that's such a huge thing. So I really appreciate your insights because it just and one thing that you said that made me feel very relatable was your longer appointment and your focus on one thing. And so on a Wednesday, I just do obesity medicine. It's like a specialty clinic.
Right.
And you're right. When you have a little bit more time, because what I find in my specialty clinic is very simple. It's the diet and sometimes it's the medicine, but what else are you doing? And a lot of it is problem solving, educating, but most of it is when people struggle, let's figure out why you struggle, and then we create a plan to address that struggle. And that way they can be successful. And that's exactly what I do in that clinic setting. Any since we've had some moments of controversy, I'm gonna get you with one more controversial question, but let me ask you this success stories. Any patient or situation that comes to mind of transformative change or a success story you can think of in the practices over the years?
Yeah, I can think of, I mean, there's a lot, but probably the most dramatic, and this is not going to be a surprise to you, is a patient who adopted the ketogenic lifestyle. He is a golfer. He is a golf instructor, and he has type 1 diabetes, actually. And so he was struggling with the highs and lows, which a lot of my patients struggle with. Kind of, they call it the roller coaster because in type 1 diabetes, your body's so sensitive to carbs and also so sensitive to insulin. So you eat just a little bit of carbs, your blood sugar skyrockets. You take a little bit of insulin, or you take just a little bit too much, and then you're crashing low. And it's just such a challenging condition to manage. And he was kind of on the roller coaster, and we ended up talking about the potential benefits of going low carb and or keto. And for him, he went full keto, and he has, amazing blood sugar control. His A1Cs are consistently below 6. And every time I talk to him, he just tells me it was so life changing. The fact that you said it's safe to go on a low carb or keto diet.
Yeah,
And that gave me the confidence to try it out and really see the impact. And he just loves the fact that he doesn't have that roller coaster anymore.
yeah,
As is the case with a lot of people when they go keto, in the back of my mind, I'm worried like, okay, like maybe he'll burn out after 3 months, 6 months, a year.
that's
But
right.
it's been 3, 4 years and counting, and he's still doing amazing on and the ketogenic lifestyle. And that's something that he believes, right? He sees the benefits of it every day. So it's not hard for him to choose to follow it every day because it's a lifestyle for him. He finds that it makes him feel better. And so
That's
um, um, he's kind of the first person that came to mind when you talked about that. But
cool.
yeah, yeah,
That's awesome. That again, my wife never had the kind of control she wanted until she adopted that dietary pattern. And again, it's the roller coaster. And the roller coaster again is not just about blood sugars; it's about your mood, how you feel. And the roller coaster, you won't feel so good. And you certainly won't interact with your environment in a way that shows your best side. So I just think I've been very impressed with her being able to do that. And again, it's nice to see some A1Cs in a better range, that's for sure. Um, I one last it may not be controversial, but I'll just ask it because I'll be going to speak to the USDA with another doctor, Dr. Mark Cucuzzello. We'll be doing that on, I guess, the 3rd of December, 2nd of December. And I'm not sure exactly how that's going to go, but it's just an opportunity to give a perspective and to lean into this metabolic health perspective. Now, having said that, there's a lot of controversy around the dietary guidelines for diabetes. I mean, we have the recommendations from the endocrine societies, et cetera. They're pretty open to different dietary patterns, but the dietary guidelines, I'm not sure about those. So when you look at the U.S. dietary guidelines, do you feel it's serving your average person with diabetes? Or do you think it makes it more complicated to get to the goal?
It's a great question. To be perfectly transparent, I don't actually know the USDA guidelines off the top of my head,
Okay.
because
Yeah, that's
I don't
cool.
follow them. Like I
You
do
don't follow
follow
it.
the,
Right, right.
well, I mean, I don't know because I don't know what they are, right? And so it's kind of embarrassing to say because I generally will follow the American Diabetes Association guidelines. We have something that we call the Standards of Care. It's kind of our Bible that we publish every year, and it's updated. And so I think what I will say is that the American Diabetes Association guidelines are actually very open ended. And I don't
Yeah.
know, once again, I haven't reviewed the USDA guidelines, but if I wouldn't be surprised if they're more open ended and less controversial than people think. I'll only talk about the ADA guidelines because that's what I know. But you hear a lot of people say, oh, they want you to eat carbs, they hate low carb diets, or you'll hear people say like, oh, they don't focus on, all they want to do is make you eat more unhealthy, and they say low carb, high fat diets are bad or something like that. And I see these in TikTok videos and Instagram reels all the time, and it's easy to buy into it, right? You're like, oh, like the government is out to get us, right? They're supported by the food industry and things
Yeah.
like that, and yes, I'm not saying food industry ties aren't concerning because I think they are, but I think when you actually look at the ADA guidelines, it's really well worded, in my opinion. It says that there's no, kind of like what we were talking about, there's no clear cut study that shows that one diet is superior to the others. It says low carb dieting can be a really efficient option. Very low carb dieting can be successful. Intermittent fasting can be a good option. Vegan diets can be a good option. So it's very open ended and says that, there are a lot of different studies that have shown success of very different approaches. Long term data is limited, which I think we would both agree, at least from an evidence
Mhm.
basis. And it's hard too because there's so many different definitions, right? We didn't really talk about this too much, but I mean, when my patients tell me they're on a keto diet, like I have no idea if they're actually on a keto diet, right? I think a lot of people say they're
Right,
keto, but are
right.
probably eating like 75 grams of carbs a day. And so, and that's what happens in these studies too, is that intermittent fasting, there's 5 to 10 different ways to do intermittent fasting. With a low carb diet, there's very different definitions of that. So when you're doing meta analysis, or the scientific way of looking all at a bunch of different studies, one low carb study might have a different low carb diet than another low carb study. So it's very hard to make sweeping evidence based recommendations, but at least the ADA guidelines are very, I thought, well worded in the sense that they don't poo poo any specific dietary strategy, and they
Mhm.
don't overly endorse one specific dietary strategy. So my hope is that
That's
that's what
right.
the USDA guidelines are.
That's
I
true.
mean, but I don't
Yeah.
know. Like I said, I didn't look at the
Well,
USDA
kinda,
guidelines.
sorta, but I agree with it. I was so happy. I think it was in 2019 when the American Diabetes Association, when the guidelines came out and they said, "Oh, low carb's okay." I was like, "Oh, wow,
Yes, that
that's a
was a big
nice
deal.
thing."
Yeah, that was a
That
big
was a
deal.
big deal. Now, big deal. And uh, just a FYI, we actually, myself, Dr. Ken Berry, Dr. Ben Bickman,
Hmm.
and a few, Michelle Hearn, who's a nutrition professional, we actually created the American Diabetes Society, and that society is similar in terms of trying to reach people with diabetes, but the goal is to really lean into the nutrition piece in a
That's
way
awesome.
that's a little, and then it's not going to be funded by industry, which, or let's just say they won't be funded by industries that actually don't help. Now, going back to the USDA and the dietary guidelines, I would say in the low carb community, there just seems to be an overemphasis on carbs, and 45 to 65% or so of your carbs coming from, I mean, your diet coming from carbs. It makes it difficult for a diabetic to be successful. They kind of, they don't say, they kind of have this like saturated fat, they demonize saturated fat to the point where they want it to be less than 10%. And we kind of know that the Journal of the College of Cardiology and other sources have not felt the same way about saturated fat in the way that we were taught in medical school. We also know that the USDA, some of their recommendations are not based on sound science. It's we know RCTs, randomized controlled trials, are better, and then we know nutrition studies is tough to have a lot of those, but a lot of their recommendations are not based on sound evidence. And so it's kind of, it's those, and I guess the last thing is that they're still kind of asking you to limit red meat. Now, full disclosure, I'm a carnivore, so I'm like, I'm gonna have a hard time limiting red meat. But the whole point of it is, we don't feel that science is strong enough to make those types of recommendations. Now, having said that, I do think that organizations, when they make recommendations, should have kind of a, tone of, there are different dietary patterns out there, and be a little bit more open to, that type of tone, as opposed to saying this is the only way. I just don't want the people I treat, for example, for diabetes, to be told they have to eat a ton of grains every day in the name of fiber, for example, but yet it's spiking their sugar. I just don't want them to be, because it confuses them. And so that's all. So that's kind of why I knew that would be a little controversial. I like the way you answered it. And I just wanted to just put that on the table, because I don't get a chance to talk to endocrinologists who are, well, let me say it differently. I've worked with endocrinologists in the conventional model, but we don't, most of the people I talk to who are endocrinologists, like Dr. Mariana Glant, who is an endocrinologist that's low carb. I'm kind of like in that little low carb bubble. So when I get somebody that's you're kind of like not in the bubble, but you're kind of good with low carb. And then I have endocrinologists who say keto will kill you. So it's like,
Right.
I'm always trying to just pick people's brain to see where they are. And I really appreciate being able to do that with you. I do want to kind of, because I know we're getting towards the end, TikTok. First of all, who the hell told you that was a good idea? And why is it that you're out there helping to educate and get to that broader audience?
Yeah, great question. So, I mean, the honestly, I wish I had started earlier.
Hmm.
Like everybody else, it was the pandemic, and we were locked in our houses. And I don't remember why I downloaded TikTok, but I did, and I was just fascinated by the amount of education I was receiving, and just like the quality of it. Like I remember at the
Yeah,
time, I think it was a lot of like financial advice or whatever, and people talking about different financial strategies. And
that's
I
me
remember
too. That's
thinking,
where I started.
yeah, and I remember thinking like, wow, like these people are really informative and educating, and just like in the medical space now, it's like people are providing good advice and bad advice, and I was like, well, I have a lot of, I have these conversations every day with my patients, but when I'm, why not record it and share it? So I actually started by making videos for my patients, and I was only sending them to my patients.
Mm.
So I had a mailing list of my patients, and I said, "Hey, I'll make these videos to update you when there's new news or if there's something that I want to share."
Mhm.
But I found that I was making the videos using TikTok, because the TikTok camera is really good and the
Mm.
editing software is really easy to
Okay.
use. So I think that got me over my fear, because I'm not naturally this like charismatic, like I want to be on camera, like doing crazy things. And like I always thought like making videos on TikTok meant you had to be like dancing and pointing at different things on your screen, right?
Right.
And so I was like never interested in making a TikTok immediately, but I was using the TikTok app and making videos and sharing them. Like it was this whole ordeal. I would edit them on TikTok. I would publish them privately. I would export it to a video program, upload it onto Vimeo, and then email the links out to my patients to the Vimeo link, which is like YouTube. It's like essentially like a YouTube. So it was private videos that I was sharing, but I was creating it on TikTok. And then my patient feedback was over the moon. They were like, "Hey, this was awesome. Like you should keep on doing this. I'm sending it out to my friends. Like this is great. Thank you for doing this." And so when that happened, I was like, oh, okay, like, and then I think that got me over my fear of being on screen, and I got more comfortable with editing, and I kind of got a flavor for like how to shorten content and how to edit. And so after a while, I was like, you know what? It's just taking too much time to edit these videos and publish it and like re-download it and then upload it to Vimeo. I'm just gonna do it straight in TikTok and share my TikTok link with my patients. And shortly after that, I remember it was like a Christmas, maybe 2 or 3 years ago. I uploaded a video the night before, and it's a video where I wore five or six different sensors at the same time. And it went viral that night. Like I woke up and I think it had like 75,000 views.
What?
Yeah.
What?
And it was maybe like my fifth or sixth video that I published. And I think right now it has like 1.4 million views. And
That's crazy.
yeah, and I think at that point I was like, hooked. It was almost like an addiction. I was like, whoa, this is so crazy. I cannot believe that this many people just saw what I made. And so so it's been really fun, and like it's been awesome. Like I feel like the reach has been amazing. I think I get patients who have found me through my TikTok or Instagram. um
Mm,
Even in industry, a lot of my industry ties have come about through that, because companies will want to talk with me and tell me what's going on. And
mhm.
and so it's been, I don't know, like I was really scared to go into it because I thought it would make me seem less professional, or maybe take away from
Mhm.
my credibility. But probably like what you found is that in your career online and being more public and on social media, is that even though that's what you're scared of, it actually makes you more credible to most people. Like,
That's
sure, there
right.
might be
That's
like
right.
3% of the population who judges you, but half of those people are
That's
probably
right.
judging you because they wish they did it themselves. And then,
That's right.
and then you're down to like the 1.5% of people, but you just got to be okay with those people not liking you, I guess. So, I wish I had done it earlier, because I look at other medical creators who started a year ago,
That's right.
a year before me, and I think a lot of it is just first to market. Because it's sad, because I see
I
other
think so.
creators like coming out now who make really great content, but they just, it's hard to gain that market and that audience.
That's
And so
right.
I'm really grateful to have started when I did, but I just wish I had started earlier. And I really
Yeah,
encourage other doctors and clinicians on this call to, especially if there's a void in your space, right? Like if you want to be a
that's
GLP-1
right.
doctor, like on Instagram, like, okay, good luck with that probably. But like maybe you're in a niche where like there's not a lot of education, right? Like maybe
That's
I
right.
have no
That's
idea,
right.
but maybe you're really passionate about psoriasis or something. And maybe there's not a good psoriatic, psoriasis doctor on Instagram or TikTok. Like find a niche and make your content. And I think I really think it's been one of the best things I've done, and I wish I put more energy into it. It's still hard to make content consistently, but I love it. It's so fun.
Yeah, you just gotta, you'll make time when it's passion, and I agree. Like, I think there's a lot of room for a lot of people. I was actually watching, uh, Angel Reese, the basketball player who plays for the Chicago Sky, interviewing somebody. And then while that interview was going on, I realized that Lonzo Ball, who plays for the Chicago Bulls, who just, is coming off injury, he and his brother, Mello, I think Mello, Ball, one of the other players, has a podcast. And then while I was watching that, I noticed that Trey Young, who plays for the Hawks. He has I mean, my God. So, but at the end of the day, you bring whatever you bring to the table, and deliver that message. It'll become what it's going to become. And but there's probably not enough people in some ways who are credible like yourself, who are out there doing this work. So I just say keep doing it and let it become what it's going to become. But I just think we need you, because we need people with enough background in the science, but who's also willing to think outside the box a little bit. Because you don't want to get into these little rabbit holes where you can't see other things, and then I think people don't do well because of that. So one of the things that I want to wrap up with is the question I ask all my guests, and that's the how you plan to protect your nest question. And what that question entails is this acronym, the nest and the rope to climb up to the nest. So the nest represents nutrition, exercise, less stress, more sleep, how you think. Positive thoughts are good. Learn from our negative thoughts or negative experiences, recovering from trauma. So that's the nest. The rope is protecting our relationships, having healthy relationships, avoiding organisms and pollutants that harm us. And the E is for protecting our emotions and making sure our life experiences serve us. So when you think about the next 12 months, when you think about what you're going to focus on to protect your nest, any areas that you would share with my audience?
Is this like a personal, like what am I personally in my own life going
Yes,
to do, or is this like
personal.
what am I going to
Yeah,
tell my patients?
it's more.
Oh
It's
man, this is
personal.
deep.
We
This is
got to
going deep.
we got to get deep, man.
Wow. All right. I feel like we should, be grabbing coffee or beers or something. So I,
Both.
I think for me, it's a lot about. being true to myself. And um, I think I'm the type of person that is kind of a people pleaser at heart. And I think I'm a very, very patient person in the sense that like I don't get angry
Hmm.
easily. I'm willing to put up with stuff. But I think like as I get older, I actually turned 40 this year, so maybe this is part of my midlife crisis.
Mm.
But I'm learning that like I think over time, like there are many ways like just putting up with other people and not putting up boundaries can be limiting
Hmm.
to myself and kind of draining energy from my own life. And so what I think, I mean, I still think it's a strength, which is like being patient and like being very forgiving. And being people pleasing. I think those are all strengths, but I think if you take it too far, then you are sacrificing your own happiness and your own, um, I don't know, you're not being true to yourself for lack of or to use a really cheesy phrase. And so I think what I've been trying to work on and what I really want to work on in 2025 is like when people do drain my energy or when there are patterns that are draining my energy and, making it harder to make good choices, like to really stand up for myself and be like, hey, like this is not okay. Or, we need to stop this behavior. Or, even like, even as simple as like workflows in my office, right? Like, I think sometimes like
Hmm.
I don't want to make my medical assistant mad, or like I don't want to ask her to do something that I wouldn't
Right.
want to do, but like in the end, it's like, no, like we need infrastructure. And if someone is,
That's right.
taking too long rooming a patient or not prioritizing their tasks appropriately, like we need to like my tendency is just to be like, oh, it's fine, it's not a big deal, like
That's
what is
right.
a minute gonna take? And like I feel like I'm being the good boss or whatever, right? But I think sometimes when you scale that, then your office becomes disorganized, and
That's right.
patients get confused, and one doctor has likes it this way and the other doctor likes it that way. And so I think it sometimes my being relaxed and chill and easy to work with, I think also makes it harder to work as a and be efficient as an organization. And I think, and that kind of leaks out into my personal life, that leaks out into my professional life. I just want to be more structured and, be put up more firm boundaries. Um, and yeah, because it's tough because I just want everybody to be my friend and to like me. And but
Yeah.
that's not always the type of relationship I have. Or yeah, so I don't know if that answered
Wow.
your question, but
You it
that's how I chose to answer it.
better than you can imagine because when I hear you speak, and I'm sure my audience will resonate with this, it feels authentic. Even when we talked earlier about the controversial things, you are authentic. I can tell you're being who you are. And I too had the same disease you had, which is, man, just nice person, want everybody to like me. And it was my leadership that helped me a little bit because I knew that there's harm that occurs when you don't do that. The book I would recommend for the listeners who are hearing our conversation is a book called Boundaries by Henry Cloud. That book helps you when to say yes and when to say no, to take control of your life. I think that's what it says on the cover. And and none of us want to be enablers. None of us want to really harm the people we care about, whether it's the wife at home or the medical assistant. It doesn't matter. We want to be in a position where we're able to say no at the right time and yes at the right time. So that book helped me to feel better about saying no and to live in my authenticity that way. So I really enjoyed this interaction, our conversation, getting to know you. And I'm looking forward to Thanksgiving too, but we're going to wrap up. Let's just make sure people know how to reach you. I know TikTok's going to be part of that, but how can people find you?
Yeah, I think the on TikTok, I'm diabetes doc. On Instagram and Twitter/X, I am on call. So it's a pun on my last name: A as in apple, H as in house, N as in Nancy, and then the word call, all in one word. But yeah, I'm pretty active on socials, or I try to be. So I'd love to interact with you guys. And I'm really glad I got to meet you, Dr. Hampton. I think it was a great conversation. I feel like we'd get
Yeah,
along really well in real life, and hopefully we do get to build a
no
friendship.
doubt.
I'll definitely be following you on socials and staying in touch that way.
Absolutely appreciate that. And again, just gracious for the opportunity. And I'm looking forward to all of that. So thank you so much. And for the audience, thank you guys for tuning in today and getting to know Dr. David On. Dr. On is on it, and he's on it on TikTok and on Instagram. So let's make sure we get to know him. And I really hope you guys who tuned in gained some valuable insights into the evolving world of diabetes care and the potential for transformative lifestyle changes, as the example he shared earlier. If you enjoyed this episode, make sure to like, subscribe, do all of that good stuff. Get the conversation going, whether you're checking it out on YouTube or on the podcast app. Make sure to connect with Dr. on TikTok at Diabetes Doc and learn more about his work as well at the Diabetes Center he's at. So, guys, we are both off to enjoy Thanksgiving. I know this episode may come out after that. We appreciate you guys checking us out. And as I always say, continue to be safe, be well, and continue to protect your nest.